Good day. Thank you all for coming. I'm Glenda Gray. I'm the director of the Infectious Disease and Oncology Research Institute, and we are very happy to host you today. For those of you who don't know, Stephen Sammut is actually a medical doctor from transplant. You started off in
Well, that was
transplant.
a long time ago.
Okay.
Yeah.
Well, you know, we all have a past, and I used to be a pediatrician. He's at the University of UPenn and Johns Hopkins University and Strathmore University, Nairobi. So what's very important about him for all of us who do a lot of product development and grant funding is he focuses on international development, healthcare and biotechnology capacity development in emerging economies, as well as the adoption of precision medicine. And so I think this is going to be important for a lot of people in the room. He focuses on the impact of the transition from developing countries, from low and middle income country settings and health systems. And he's currently engaged in postdoc research at the University of Cambridge on the relationship of economic development and healthcare in emerging frontier markets. And he even has one of his students that met him at a restaurant.
I was going to introduce him.
That's come to listen to him, but I'll leave it to Stephen. So we're very happy to have you, and thank you very much for coming.
I'm delighted and honored to be here with you, and I hope the messages I have for you today will be, if not immediately useful, at least perhaps encouraging. And I will, at the risk of embarrassing him, Garakai Govati, known to those of us who love him as Gaza, was my teaching assistant 13 years ago already. And so I asked him to come, not only to see him again, but I had the ulterior motive. I grade on class participation, and he'll be tracking that for me. So what I wanted to address today, I hope you will find very topical. And given the way that a scientific career progresses pretty much from undergrad years through grad school and into research fellowships, is that there's been a built-in and presumed dependence on public financing of research. And this has been the way it's been for a very long time, and you could trace that back even to the Italian Renaissance. But unfortunately, we've very abruptly and without warning moved into a period where those resources have become extremely scarce. And I can't say that I predicted that would happen, but the trends over the last few years have been very suggestive that something like that, where a reduction would happen. And the reason has to do with the global economy in some ways looks very strong, in other ways does not. And most countries are profoundly deep in debt. The United States, which is the kind of principal culprit right now, is facing national debt that basically is costing $1 trillion a year just to finance. And that takes a lot of stuffing out of the economy. And moreover, now, for the first time, we have an administration that understands the importance of protecting the dollar as the global reserve currency. Because if that changes, it's going to have profound effects on the American economy forever. And you can write off American participation in global aid if that happens. I'll give you one interpretation of what's going on with the trade wars and with tariffs. I can tell you the administration is extremely uncomfortable with the role South Africa is playing in BRICS. And the principal purpose of BRICS is to unseat the dollar as the reserve currency. So as long as this is part of your political position, you're going to be in the crosshairs of this administration, and you just need to understand where this is coming from. All right, so I'll try to deal with things more positive. So what what I've subtitled my talk as is the necessity of engaging with the private sector in an era of diminishing international aid. And while different institutions and different investigators have had long histories and successful histories of collaboration with industry, by and large, that has not been part of the academic research ethos. In fact, there are many institutions which essentially will not acknowledge, for purposes of tenure and promotion, grant money from anything other than R01s or federal support. And I don't know what the case is here at Wits, but in much the same way that journals, only publications in specific journals count, the source of funding counts as well. So as a result, relatively few academics grow up with the process of understanding how industry works. Moreover, there isn't a company in the medical world, be it pharma, biotechnology, medical devices, diagnostics, that isn't committed to doing the right thing. They all have ESG programs, they all have impact programs, they do want to participate in support, and yet they're not exactly sure how to do it. They are great at coming up with philanthropic programs, but oftentimes these are not systematic and sustainable, and they serve only a very short focus. So it's a nice story to tell your shareholders, and everybody can feel good. And I can tell you that the employees of companies like Merck, regarding their river blindness program of now 30 years, which has cost Merck easily $3 to $4 billion over the years, this is something that you ask any Merck employee what do they like about Merck, and probably the first thing they will tell you is the ivermectin program. And it's a recruiting tool and a retention tool. And companies would like to do this. Now, what they haven't figured out yet is how to connect the dots between what they're learning in these philanthropic programs, this so-called corporate social responsibility, or CSR, how they can translate that to their ordinary business and begin to turn that into a tool for cultivating sustainable markets. This is something now that they're thinking of. I can't promise you that they're going to have rapid solutions, but the stars are coming into alignment. So just as a time you're going to need to diversify your sources of funding, the pharmaceutical companies are rising to the challenge. And the other dirty little secret is that pharma knows that it is, over time, entirely dependent on the basic science and discovery work at institutions of higher learning, and that this forms the foundation of the products that eventually come to market. Yes, they invest in the intellectual property, the development, the clinical trials, the manufacturing, and so forth and so on. They know they have to do with that, and that represents a massive cost, but none of it would be happening without the fundamental contributions of modern biology going back 80, 85 years. And that stands in jeopardy right now, and they know it. Now, they cannot finance that the way governments have, but they are going to be looking for ways. So what are my goals today? I want to argue that private sector engagement is a countermeasure during this period of funding that we currently find ourselves in. And by that I mean diminished international aid. If I can ask, are any of you from the business school here, or economics? No. Where there's a seat. So I have a full house. I can't believe it. I wish my students were as conscientious. The reason I ask if there's anyone here from the business school It's one of the things I really want to do, and I'm hoping to do this with Cambridge and Wharton and places like Wits, is enlist international academic collaboration in research on the role of the private sector in global development. Because the theory really isn't there. The theory has been concentrating elsewhere. I think most of you would agree. And moreover, corporations actually do seek academic guidance to get into new areas, and they do not know how to make the transitions I described to you. So we're going to have to fill in with some really good theory and recommended best practices, and that's not there yet. And I want to promote research on corporate strategy and tactics for effective participation in global development through commercial success, because at the end of the day, shareholders do have to be satisfied. Secondly, establishment of a development finance curriculum built around the private sector. The international economics programs and development finance programs that exist are all public sector oriented. Haven't really paid attention to this. And finally, collaborate with others in the development of programs for students and executives with all the things that go along with that to help build the case. The only way we have a paradigm shift here is if we really provide the foundation for it. And my goals today are really to try to enlist some people in this thing I want to build. So I have 4 prompts, and I've color-coded them, more for my benefit than yours. And what I'll be doing is at the conclusion of the discussion of each prompt, I will pause and we'll take a question or comment or two and then move on to the next. The first prompt, which is the briefest of them all, traditional international aid mechanisms are weakening. For example, USAID, cuts. But there have been other trends with development financial institutions, not so much the World Bank, but all the nationally based programs are rethinking the resources they want to allocate, or they're re-strategizing what that's going to look like. And in addition to being an academic, I'm a partner in a private equity fund called Alta Semper. We're headquartered in London. Among our limited partners or investors are development financial institutions. So we've been seeing how their own strategies have been evolving. And they're after things much more fundamental. And by that I don't mean basic research, but things that will contribute to economic growth. And the big issue right now for those of us that do healthcare, and that's all Alta Semper does, is the determination and articulation of what impact criteria really have to drive us. And we're putting a lot of study and effort on, we have a group called Investors for Health, and I chair the research for that group, and it's something we're studying very closely. So that's the red prompt. The blue prompt is that rising health inequities in LMICs demand new models of participation. That'll take me a while to develop that. The third, in green, is the impact of graduating into middle income status, something South Africa has done for a while, but you're kind of in the middle of the higher income, middle high income. And as I explode out the issues there, I think a lot of them will resonate with you. So to avoid the middle income trap, there has to be much greater engagement with industry and increase in foreign direct investment from the private sector. And then finally, in the violet, private health-related companies, or for short, health enterprises, are uniquely positioned to lead health innovation for impact. So these, I don't know if I'll get through all of these, but this is the goal. So what's happening with global aid? Well, since just before COVID, things have been largely flat or declining in real terms. COVID gave it a little bit of a boost, but that was somewhat artificial. But these numbers in real terms haven't been moving out. And when you strip out refugee hosting, which is an interesting euphemism, isn't it, and Ukraine-related spending, core development aid has barely moved. And so that was already a trend in place. So there was a vulnerability that we all had. The future of aid is the sustainability of the aid levels is going to be increasingly challenged as the donor countries, including China, face budget constraints and shifting political priorities. And we're seeing this almost as a global phenomenon. Donor calls, especially from the UK, are underway in rethinking what the architecture of global aid looks like, and involving broader actor networks beyond the traditional Development Assistance Committee, or DAC, countries, which is a subunit of the OECD. So this is going on in these meetings, and I'd love to be a fly on the wall in a few months at the G20 to see what's really going on with aid. So if any of you have access to those forums or cocktail parties, yeah, you may want to kind of probe this yourself. And I suspect they have really good cocktail parties. The other thing I want to do as a backdrop to this talk is restate what is now, we've moved from the triple aim of healthcare to the quintuple aim. And what I've tried to do here is restate those principles from a private sector point of view, how they get translated. So the issues of access, quality, cost, the welfare of providers, and global health equity, they mean something very special and important to all of us who are providers, but they look a little bit different through the lens of private enterprise. So this translates to growth through creation of new sustainable markets. You know, that's what access is all about. Deliver acceptable financial returns to shareholders. That's a translation of cost effectiveness. Meet impact objectives of stakeholders. That addresses quality. Different than the way we state it, isn't it? But that's what's going on. They also want to promote development of policies and infrastructure to encourage the role in global development. And finally, the industry does recognize that until we come to some different understanding and progress in health equity, that their markets are going to be stagnant. Or what they're going to be doing perpetually is looking for new, I'll put in quotes, invented diseases in the West for which they can sell pharmaceuticals, and not engage more thoroughly into discovery research oriented into health issues that confront the South, the global South. And this is something we have to look at. All right, so let me pause there as promised and see. Any reaction, thoughts, questions to my first prompt about global aid? Am I preaching to the choir? Have you all seen this? Any thoughts? And say your name so that Gaza can write down your picture. Wendy.
So I think we've heard these words before,
Mm-hmm.
but we're very weak at translating it into action.
Well, that's right. That's the purpose here. That's why this is the briefest section of the talk. It's not an easy translation.
But what is so global aid is, you showed global aid declining over time.
Mm-hmm.
And obviously the big drivers of global aid are the USA, some European partners, and the UK partners. But if at a global level aid is declining, it must be that the high income countries are not seeing a return on their investment, so to speak, and that's why that's declining.
That is certainly part of it, and we only see a resurgence in global aid when there's some kind of catastrophe to drive it. And that's why I pointed out the Ukrainian issue in all of this and the response to COVID. I think one of the things that changed the whole premise of international aid from a geopolitical point of view was the end of the Soviet Union, because so much of international aid was driven around the Cold War, in response to the Cold War, particularly as it related to Africa, and lesser extent to Latin America, and to a very significant extent Southeast Asia. All right, so we've been, this is already now, what, 35 years? And we still haven't redefined aid in what is apparently a unipolar world, but really isn't. So the leadership, like the Trump administration, is questioning what do we really do with this. And they were surprised to find how a lot of the U.S. AID money was being spent. And I think one of the supreme ironies of what's happened with USAID is that one of its best programs, PEPFAR, was an invention of a Republican administration under George Bush. And I thought PEPFAR was going to be secure almost entirely for that reason. I was very surprised. And yet it got dragged into the culture wars underway in America. And that's what's gone on. Yes, sir, please.
Hi, Bhavesh Khanna from the School of Pathology.
Yes.
I mean, so to extend this idea that global aid is declining, I think that a really important part of the conversation is it's not just about the money that's gone, but we've spent our entire lifetimes building relationships and ecosystems that have been dependent on this money.
Yes.
Partnerships, international cooperation agreements,
Yes.
bipartite agreements, memoranda of understanding, and fundamentally this thread of trust that was the foundation of global health. And I think that the money is one issue, but the biggest casualty has been this trust. So we've been separated from our American colleagues by a policy.
Mm-hmm.
We've been physically and fiscally separated by a policy. And I think that when we think about how we go forward, we need to separate the aid from international cooperation, because the international cooperation needs to continue, right? All private sectors are not equal. Like if you look at the one here in South Africa, it's very different to the one in the US, it's very different to the one in India. And if we're moving to an era where we don't trust each other anymore because of what's happened, I think then the world is going to look very different. And I'd be interested to hear your thoughts on kind of what the ramifications to the ecosystem, not just those that are related to funding.
Well, I started my comments by alluding to this ecosystem of basically each one of you growing up in an environment with public supported science. And I think implicit in that is everything you've just described. International cooperation, which has been on a very significant upward trend, a lot, in fact, due to improvements in IT and the internet and the exchange of information. But even again, once we moved away from the Warsaw Pact and the Soviet Union, books and journals that were not available to scientists in Eastern Europe have been for the last 25, 30 years. And that's kind of expanded the entire global scientific enterprise in ways that it hadn't. And the extraordinary economic development over a very short period of time in India and China and elsewhere, the contributions in the literature to intellectual property, even eligibility for grant funding from European and American granting agencies increased. That was all evidence of that trust that you speak so eloquently to. My feeling is that the scientific community at its conferences, formally and informally, is going to have to find in themselves a way of just overcoming that and saying, because in the long run, you're going to be more powerful than the governments. It doesn't seem that way right now, but you are. And I, as someone from a business school, I think in terms of markets and marketing, the scientific community has not really done a very good job of educating the public as to what you really do and what's involved in it. You're not, when you're the subject of a Hollywood movie, it's usually something negative, like The Constant Gardener. It is, what goes behind the breakthroughs, the extraordinary progress in HIV. People don't know anything about that, or if they do, they think it's been solved. And they have no idea about, and HIV did not end with ARVs. And just what got us to ARVs alone is extraordinary science. But what's been going on since then, people don't know. I think part of it, and I'll throw something back at you, I think part of that is the responsibility of the scientific community. Because I've had a lot of friends who are popularizers of science who are almost censured by the scientific community for trying to educate the public. And only people of the greatest stature seem to be able to go down that pathway. I'm thinking of my friend Francis Collins. I mean, he can talk about science and the importance of it, align it with his personal faith, and he's not censured by the scientific community. But for the most part, rather than encourage the public assimilation of science, it's almost been suppressed, and that has to change. If the public really understood what goes on in the laboratories and how dedicated scientists are, that you pretty much decide when you're in high school that you're going to dedicate yourself to medicine and science, and what you go through to get there, and that you probably don't even have a reliable salary until you're 30 years old, or older. Yeah. I don't think the body politic could possibly have done what they've done. There would have been too much of an outcry against it. So this is, if anything, this has to be a time where there is a resolve by the community as a whole to do this. Just an example, you're in pathology. As was announced, one of the areas I study is the assimilation of precision medicine. I'm of the view, and we can talk about this afterwards if you'd like, is that precision medicine is going to change the fundamental nature of pathology, because you control what happens in the laboratory, you're controlling the interpretation, and probably for the first time your role is going to be more prospective in medical treatment than retrospective. If you do it right. That's right. And that has to be communicated within your community. And I think the public has to understand that. They have to be given the information they need to connect the dots. So I don't know if I responded to your point of view. You're welcome. Let me move on, okay? The second prompt, rising health inequities in low and middle income countries demand new models of participation. Okay, just to level the playing field, by global health equity, I refer to the principle and practice of ensuring that all people, regardless of where they live, their socioeconomic status, race, gender, etc., have fair and just access to the resources, opportunities, and conditions necessary to achieve optimal health. Of course, at least within the context of their own national economies, but with participation. Now, what this means, in my mind, is that the cutting-edge technologies that are emerging in Europe and Japan and China and America must not further exacerbate health inequity. We have to find ways of making them efficient and more available. And the whole purpose of my trip on behalf of the University of Pennsylvania has been to investigate how South Africa can collaborate with Penn and further accelerate, which you already do CAR-T in the country, but where can it go from here, and how can it be done in such a way? In India, there's a wonderful company called Immunil in Bangalore that's affiliated with the Narayana Hospital that is actually working with Penn to find ways of bringing the cost of CAR-T, which can be hundreds of thousands of dollars, down to $10,000, which for most countries is still a lot. But when you juxtapose a cost like that against what it's costing you using conventional cancer therapy, it's not that obscene a number, especially if CAR-T can become a first line of intervention in cancer care instead of what it is in the United States, which is almost a treatment of last resort, by which time we've already spent $250,000 on a patient. Where Dr. Vogt and I are arguing, and as shared by your colleagues here, that what better place than South Africa to see if CAR-T can essentially help leapfrog oncology care across the continent by becoming a first line of therapy. So that's kind of one of the ways of thinking about this, Wendy. All right, these are just the key, I'm not going to go through this in detail, key elements of global health equity. It has to do with fairness, not just equality, addressing the root causes of health disparities, redistribution of power and resources, global solidarity and justice, and finally, inclusive participation. These are the ideals, the goals, these are the moral imperatives that as scientists and clinicians we're all after. So what about the text? This is the translation that Wendy challenged us on. Because of who was involved in hosting this and what the mission of their group is, I decided to, as by way of example, focus on diagnostics and in combination with AI platforms. You're welcome. So the key role here is early disease detection, triage, which is incredibly important in a realm of scarce resources. And given the nature of demographics and the nature of the African continent, remote care delivery. We need other ways of doing this, distributive medicine, I call it. The value to LMICs has to be affordability, scalability, and the ability to leapfrog the infrastructure gaps. So this should be part of whatever research proposals there are. And I suspect when you are writing grants now for support from a pharmaceutical company or a diagnostics company, what will resonate is how you're going to work with this technology and leapfrog over what's there. In other words, how we're going to accelerate the commercial opportunity in this country. We have to proliferate the presence of healthcare professionals. And by presence, I mean we are not in any of our lifetimes going to have an adequate number of physicians or an adequate number of nurses. We need to redefine allied health professions. We need to extend the role of physicians. We need to expand the authority of nurses, make it more worthwhile to have a career in nursing. If we don't do that, we're going to have a perpetual HR crisis. And there's no way of getting around that. So here's a sidebar, and here's where I, for a moment, get a little academic. How do we apply theory of change to the kinds of things I've talked about? Well, I have basically 5 touchstones. What is the goal we're talking about? So, for example, here one of the theories of change is expanding access to early detection and remote care solutions. The inputs, research and development for frugal innovation. Now that's a cute term, isn't it? But the Indians have a term for it called jugad, about thousands of years old, long before we were talking about these kinds of things. And in terms of south to south, or from south to north, reverse technology transfer, here we're talking about what can be learned from countries that have been successful in their medical systems, in their environment of scarce resources, where nevertheless, what they've done is still producing great results. So one of my heroes in the world, and those of you who know me know, is Dr. Devi Shetty at Narayana Hospital in Bangalore, who basically decided decades ago that everyone in India should have access to needed cardiac surgery, irrespective of cost and irrespective of their ability to pay. So he introduced innovations into the way surgery was done, looked upon it as a production challenge, came up with some very novel ways of people paying, and some people pay next to nothing. It may be a lot of money for them, but it's next to nothing. And Narayana now, for decades, has done more cardiac surgeries a year than anywhere in the world with the best outcomes. I like to joke around and saying, the more you do of something, the luckier you get. But obviously, what's really going on there is they've mechanized it. And Dr. Shetty now he's about my age. He's kind of at a point where he wants to export what they've learned and what they've developed at Narayana to the rest of the world. And there's a project I'm working on with his team and some of my Wharton students with electronic health records. So that's where we go. But so what we're looking for are this reverse innovation, public-private partnerships, and digital platform deployment. These are the ways we have to translate, and all of these are points that are going to attract the interest of industry. Activities would include the launching of low-cost diagnostics. When do you know anybody working on that? Training technicians and CHWs, community health workers, which are playing a very important part. Again, in India, the community health workers known as Ayush basically work their villages using technology developed by the Public Health Foundation of India, where they use an ordinary, well, it's not an ordinary tablet anymore, but they have tablets that will do nearly 50 diagnostic tests through telemetry, send the results back to a lab, and then get direction as to what that can be done in the field. This is a remarkable breakthrough. I don't want to trivialize it because it's taken the better part of 20 years to get this to work, but it is part of it. And then finally, deploy remote triage tools through the use of AI, which is probably a lot, unless you've been playing with ChatGPT, you may not be aware of just how rapidly that's moving. It's terrifying what it can do. Outputs and outcomes, increased diagnostic coverage, better clinical decision-making at POC, a local capacity for use and maintenance. This is what we're seeking to get. And the outcomes have to be earlier detection of disease, phenomenal cost and outcome implications of that, lower cost burden on systems, and expanded market share and user base. These are all things that are going to resonate with industry because these translate to financial gain. The impact, well, I think these are all self-evident. Stronger health systems, improved health equity, revenue streams that are reliable, where the private sector really becomes part of the ecosystem in ways that it is now. The expansion of human resources as companies become more ingrained in the local ecosystems, they're going to have to participate in the training of not only health professionals, but business people, marketers, and the like, and in fact scientists. Maybe reorient the way some of you do your own thinking. And the impact would be less reliance on aid. So I've broken out the implications for diagnostics and pharmaceuticals. I won't go through this, I'll just let you glance through it. But I broke the categories into focus, innovation, path, access barriers, business models, and development collaboration, and then have a list, which you can debate with me if you wish, diagnostics and artificial intelligence and pharmaceuticals. Some of these are very interesting, some of them are not scientific. So for example, development collaboration in the area of pharmaceuticals has to do with drug donation, but pooled procurement as well. And I'd go so far as to say that one of the vulnerabilities of the African continent is the lack of medicinal sovereignty. And that is, while South Africa and Morocco do contribute to production here, it's a very small portion. It's less than a quarter of the pharmaceutical needs of the continent. Somehow we have to build on the African continent, in collaboration with others, capacity for discovery research. And we have to make the case for that, and the case will become stronger and stronger the closer we get to having the African genome. So what you showed us in your laboratory yesterday, I found really exciting. So, you know, we have to progress with that. Tactical roadmap for medtech companies. Wendy, I hope this gets a little closer to the what you were asking. The private sector needs to establish global health units with key performance indicators driven by impact definitions. And I'll clue you in on something. One of the flaws in international aid, since it emerged after the Second World War and after the Bretton Woods institutions that were founded at the end of the Second World War, is you have a bunch of well-meaning but paternalistic and probably arrogant wealthy Westerners deciding for beneficiary countries what those countries should have and how much they should get and what would serve them best. So where they said, oh, you need a dam, it never would have occurred, you know, to that population, oh yeah, we need a dam. It's only recently that the donors have now begun to recognize that, gee, maybe it's a good idea to ask some really smart people what it is they need from their own perspective. And this may sound so obvious in some ways, and yet it is an entirely different way of thinking. And I think the beneficiary countries now really have to sit down with the corporations and say, we appreciate your interest in being with us. Let us share with you our perspective on what we need. So just do a little thought experiment at some point. You know, if you were to ask a patient diagnosed with cancer, the day or two after cancer, what is your goal? Well, that's going to depend on that person. If it's someone in stage 3 or stage 4 of their disease, they may say, my goodness, if I can still be alive in 6 months when my first grandchild is going to be born, that's success for me. Or if I can die with dignity and bring me down a pathway of palliative care, that's success. Whereas if I'm phase 1, or maybe even a little earlier, yeah, let's go for the cure. But let's participate in that definition of what a cure is for me and how we get there. There are many physicians who exactly practice medicine that way, but I'm not sure the system as a whole is oriented like that. So it's another way of thinking. We have to, so basically what I'm saying is ask the beneficiary what that impact really is and define it accordingly. And I think you will find it is much more manageable and fundable than the more grandiose ideas that we have. We have to invest in interoperable digital diagnostic platforms, co-create solutions among, I wish I had said among, LMIC partners, use blended finance to scale pilot studies, clinical trials, embed the Sustainable Development Goal 3 into our impact reporting, It's appalling the number of executives, or for that matter, even MBA students, who never even heard of the SDGs, let alone use those as guides to what we were seeking to perform, and then to invest and build in permanent markets. That's where the sustainability comes from. This matters now because, as I think I've made the case, traditional aid mechanisms are weakening. There's rising health inequity in LMICs, and we need to find new models of participation. And medtech companies, more so than ever before, with the right guidance and collaboration and participation, basically are positioned to lead health innovation. But it's initiatives such as you have here at Wits, under Wendy's direction, that I think are a very important component of that, and leadership. So I hope you'll be writing a lot more about what you're doing, or make movies about it or something. And although I don't know who we could possibly cast for you in the movie. You can think of a few, okay. So the required action, we have to transform diagnostics and AI platforms into agents of equity. We have to think of access not as charity, but as long-term investment. Reframe innovation around usability, and partner deeply, measure honestly, and scale sustainably. Those are my buzzwords. These are just the ecosystem roles in global development. I've plotted these out. And these slides, I'm more than happy to distribute them if you wish. So let me pause there. That was the end of the blue prompt. Any comments, questions, disputes?
Yeah, I have a comment, and maybe Bhavesh and I and Patrick. So some of us work in programs where the only people that see the public health good would be governments, and so trying to find a TB vaccine or an HIV vaccine. Pharma has been there, done that, and are not interested. And so sometimes...
Well, it's not that they haven't invested, they haven't gotten the results they expected.
You know, I mean, because it's a long haul finding an HIV vaccine and TB vaccine equivalent. And so sometimes the kind of model that you talk about, it may work for a rapid diagnostic for cancer, because I can see the market. But so Bhavesh, maybe it might be good for you to talk about your mimicry and the kind of, which seems like an obvious place to have a good market, but because it's a diagnostic for poor people's disease, you know, the market is not as lucrative. So maybe you could just comment on the work that we do, trying to find an HIV or TB vaccine, or your diagnostics in TB.
I mean, I think it's an important point. I mean, I really like the thread that you're pulling through, because we do need different models of cooperation. Mm-hmm. But I think these medtech companies are also finding themselves in interesting spaces. So in addition to a TB vaccine or an HIV vaccine, just drug discovery for these diseases and neglected tropical diseases are something that these companies are running from, because they can't build a sustainable business model around them. So TB is a good example. We've had the first new TB drugs in 50 years developed by Janssen, and they've declared this an economic failure, simply because the people who need the drug can't afford to pay for the development cost. And so effectively, using this as an example, you have companies like Novartis, GSK, Aspen, all moving away from developing antibiotics. And if you put that together with the pace at which antimicrobial resistance is developing, in 10 years' time, we will be doing medieval medicine.
We're in great danger.
We're
it's
in
going to
great
be
danger.
the 19th century all over again.
And so I think, I mean, I definitely agree with what you're proposing, but I'd like to push you for more nuance, because this international aid disappearing is an entire ecosystem that has just gone up in smoke. Right, and medtech companies, it doesn't matter if you're as big as GSK or a small one coming out here in South Africa, they can play a small part in the ecosystem, but the guts of the ecosystem has evaporated.
Sure.
And I think we're going to need to push harder to keep interest, from all the parties still.
Yeah, Doctor, I understand the point, and maybe I didn't emphasize what I was saying earlier enough about defining impact. When it comes to vaccines or interventions pharmaceutically, the old saying, "the perfect is the enemy of the good," applies. And if you're defining a TB vaccine as something for all, essentially eradicates TB, that is a bridge too far, probably. It almost has to be approached incrementally. You know, what can be done now? If we're looking for a vaccine that is going to protect an entire population, that would be a wonderful thing to have. But is it reasonable to expect, given where the science and the resources are now, or is there something between where we are now and then that will satisfy some critical objectives that could be funded much more easily and through international cooperation be regulated in a much more collegial way? I think this is one of the ways we have to think about it. And, you know, I have tremendous respect for Bill Gates and what he and Melinda have done. But to some extent, you know, being the kind of business person he is, he's kind of guilty of that as well. Not happy until we eradicate polio. Are there some steps in between where we are now and then? Can resources be deployed differently? And this is what I'm saying. And you know, in the case of the Ebola vaccine, apparently what we have now is a good protective barrier, but it's not been tested in reality yet. So we don't know what its full impact is going to be. But
Can
this
I,
is...
while I have it, okay. Okay.
So, so an example about like market failure that we have at the moment. I'll give you
That's actually an imprecise...
I'm
Market failure...
I'm not
Yeah.
talking about Ebola. I'm just talking about... I'll give you another example about how the global... the ecosystem in global development is nuanced. So I'll give you a nice example, an easy one. Oral cholera vaccine, where you can immediately see the pool procurement, you can see the value chain. It's equally applicable to both the developed and developing world. And a tech transfer, and Sanofi Pasteur has disengaged. They're not interested in the oral cholera vaccine. So a tech transfer happens for a company in South Africa, Biovac, and even Biovac's shareholders and won't invest in the tech transfer. And the tech transfer is picked up by philanthropy and maybe the public purse. Even though you have global supply chain, you could get onto the Gavi pool procurement, you know, so even something like an obvious story like an oral cholera vaccine doesn't fit. The only thing that fits into these kind of global development ecosystems is probably cancer, because there's interest in the global north.
Well, everyone understands cancer.
Yeah, but I mean, so for me, so for some infectious diseases, the model is much more problematic, because we do need the public purse to involve
we do,
in
but
that.
you know, here again, I get down to this issue of education. So unless you read or seen the movie based on Somerset Maugham's book, The Painted Veil, you probably can't relate, unless you've lived in a cholera zone, to what it is. And a lot of people think that, oh, cholera was eliminated when a pump handle was removed in London, you know, in the 19th century. Well, it helped for a neighborhood. Again, very few people can relate to what cholera is all about, because we've lived in places with good sanitation. And the whole anti-vax movement, I think, has a lot to do with the fact that people have forgotten what the effect of measles or or chicken pox and what they represent. So there's a constant need to re-educate. Yeah, great book if you've not read it is The Ghost Map. It's basically the story of the invention of epidemiology. Really worth reading, and it centers around Jon Snow, not the one from Game of Thrones, but the real Jon Snow, and the way he reasoned through finding ground zero or patient zero. So, any other points? Because I'm pretty much out of time.
I would just like to say that diagnostics, even, you know, you probably a bit easier than vaccines, but there is no money really in the research and development. So, so I'm just saying, to get research and development money
Mhm.
for diagnostics might be better than trying to look for vaccines, but it's still such small amounts, you know, that we have to focus essentially just on needs-based
Yeah.
innovation.
Well, if you don't have a vaccine for cholera, what's the next best thing? Surveillance systems and diagnostics to predict when it is a real danger, and to have strategies, social strategies in place where it's needed. I mean, we pretty much know when a country is or a region is going to have a risk of cholera. But if we have empirical ways of testing the water, seeing what's going on, and can respond. So unfortunately, in public health, not all of it needs to be a vaccine or a pharmaceutical. We may be able to achieve the same objectives. We might not be as satisfied scientifically with the solution, but we have to think in terms, what else do we know that would achieve the desirable result? All right, well, as Gaza can tell you, I never get through a lecture. But this is less than half of what so I won't spend a lot of time on this, the graduating into middle income status. This is pretty well known that it affects eligibility for international aid and concessionary policies and the like. When you are a low-income country, these are some of the good things that can happen. Otherwise, these are some of the negative consequences. So I'll go through those. So South Africa, as you know, you are an upper middle income economy, and your global national income per capita, from what I can find, I couldn't get what I thought was a reliable number. It was in the 6,000 or 7,000 range. The graduation into high income is about 14,000. So there's still a lot of room. But the examples of countries on that cusp, we see in Africa, well, not just in Africa, Ghana, Nigeria, Kenya, etc. They've reached lower middle income status, but have high debt burdens, underfunded health systems, and inequality. And now there's less opportunity to fund that. Just by way of example, Kenya's national health accounts, nearly a third of the health economy of Kenya is reliant on external funding and donation. All right, and most, if not all of that, has to do with HIV. But and Indonesia and Vietnam, they've navigated some aspects of graduation, but still have very uneven development and reduced aid access, and a further and further polarization of wealth in the economies. So what happens in areas of health? Donor aid declines, domestic health financing has to increase, but most economies cannot fill that gap fast enough. Health health service coverage inevitably then declines or stagnates, and this underscores the importance of a sustainable transition plan from donors having a different value proposition and relationship with them, strengthening domestic revenue systems, and maintaining equity-focused investments in health. I mean, these are at a high level the interventions you have to take. So the middle income takeaways is it's graduation to middle income status is not an endpoint. It's an inflection point. There's a very big difference. Without intentional policies, good planning, continued global support mechanisms, countries often fall into a middle income trap. And what happens in the middle income trap is that there's slow growth or stagnant growth, reduced external support, and persistent and growing social inequities. So if that sounds familiar to you, I rest my case. So can private sector address this with you? Private investment brings capital formation, which can promote infrastructure and needs that can drive output and income, expand the work base and the like. It drives diversification. It shifts economies from reliance on commodities or agriculture towards more value-added sectors like manufacturing and services. If we could roll back the hands of time, the mineral extraction from South Africa alone, had that been woven more into value-add products and not commodity products, the economy and justice in this region would look very, very different than it does now. That's easy to say, very hard to execute politically. There's job creation and poverty reduction. We're looking for employment opportunities, especially in things that address infrastructure. Those are generally very high-paying jobs with very long-term impact when done properly. Livelihoods breed good livelihoods. And what happens in Maslow's hierarchy of needs? When people make more, they want certain things first, and then they begin to aspire to things. So they addressed food on the table, roof over the head, education for the children, health for the family. And once these are satisfied and confidently satisfied, basically people then start thinking about how do we upgrade our lives. And basic education becomes, well, now we want stronger secondary education. Then we want higher education or vocational technical training for our sons and daughters. So it moves along those lines. Modernization through tech transfer, foreign direct investment brings in advanced technologies, and then accompanying that is skills development. With infrastructure development through public-private partnerships, it's a very different way of thinking about development. And the private equity industry has actually emerged into this, where more so than ever before, they're investing in infrastructure. And if you have the choice between getting the money from a private equity fund versus your friendly neighborhood major country or non-neighborhood major country, you're probably better off going with the private sector. So there's a lot going on there. And the people doing infrastructure investing have gotten a lot smarter about how to do it. Then there's urban development. We need to find better ways of private capital participating in housing needs. The desire is there, the capital is there, the methods for doing it are not yet. And then finally, integration into the global value chain. Export competitiveness by more strategic investment in manufacturing, moving as much as possible to an export economy. And this is, think about it. South Africa is, relative to other African countries, a large country, but not in and of all by itself a market. What you develop here and manufacture here needs to be exported, and that brings in foreign exchange, especially as long as everything is denominated in dollars, it works. And then global market access, private firms connect domestic producers with international buyers and standards. So this is what we're after. Reducing dependency on the public sector, that's a very American thing to say. I realize it doesn't work in all social settings, but I think generally the more independent and self-reliant citizens can be, probably the better off they are in the long run. Fiscal relief, private investment reduces pressure on governments, and governments know that now. One of the things I will tell you is I've consulted for many governments in the world, through the World Bank and otherwise, on how to make a country most appealing to private equity funds and venture capital funds. And this is not because the World Bank is telling them to do that, but because they're seeing the impact on job creation and employment by investment in private capital in European and American and Japanese companies, and now in China and more recently in India. And they're saying, wait a minute, we want in on that action. So what do we have to change about the way we do things in order to attract more private capital? So the message has been received. Now it's political transition that needs to occur. So what are the challenges to reaching these benefits? In many middle-income countries, political instability, weak institutions, et cetera, are in the way, and inequitable growth may occur if investment benefits are not widely shared, or if sectors like extractive industries dominate. So, these are some of the hazards that a society has to overcome. So let me, I'll take one question in the interest of time on that third prompt on middle income status graduation, if there are any comments. We'll wait till the end, all right. And then the final prompt is that private health-related companies or health enterprises are uniquely positioned to lead health innovation for impact. That's another way of saying that healthcare is actually uniquely positioned as a human endeavor and an economy to really drive a lot of these other things, because fundamentally we're all concerned about health and longevity and well-being and the like, and it's something every citizen can relate to, and if they're given the political power to express themselves in the voting booths, it's something they will demand. So what are the strategic approaches for corporate engagement and development? Shared value creation. How do we align business success with social progress? This is very philosophical, but until we can articulate that and come to agreement with corporations who will be very willing to listen, we're not going to make the progress. The tactics for doing that are to develop the stuff that meets underserved needs by building inclusive supply chains that integrate smallholder farmers or local small to medium enterprises. And also, how do we lift up the employment base through training and addressing the high unemployment regions. Now in Africa, this is as much a demographic phenomenon as anything. But I mean, one of the principal goals of the relationship with any industry here is, yes, please come manufacture here, but hire and train as many people as possible. And that has to be really one of the categorical imperatives. Market expansion through development, entering emerging markets by investing in local infrastructure, education, et cetera. The tactics associated with that are partnering with local governments or NGOs to improve market readiness. This is something that a good corporation, and as Gaza can tell you, our marketing professors at Wharton have always stressed this, pre-market conditioning, This is something we must have to do on national scales. Involves a lot of education. Provide digital or financial literacy training, which is something that is lacking in most societies. And then support infrastructure development that not only serves local needs, but serves business needs as well. And this, of course, is what's driving the interest of China in investing. Once they build the rails and the roads and the ports through which they can ship the things they want either into the country or out of the country. So they've gotten that. And in the old days, the US understood that too, but things changed. Corporate social innovation, or CSI, the strategy is to create new business models that solve development problems but remain profitable, and by using R&D to innovate around constraints. So for example, low-cost solar products. And then apply reverse innovation, the thing we were talking about earlier, to scale emerging market solutions back to developed markets. There's a lot of money in that, not necessarily for the sale of that technology, but for making things cheaper to produce in developed markets. So what are the tactical instruments for engagement? I hope this gets closer to what you were asking, Wendy. We are at a period of time where we have to be thinking about impact investing and blended finance, and that is finance directed at for-profit motives as well as development. Having capital flow to ventures that deliver financial returns and measurable development outcomes. And who defines those development outcomes? As I pled earlier, the countries, the beneficiary countries. The tactics would be to set up or contribute to corporate impact funds. Many corporations are doing this now. It's very small relative to the size of these corporations, but they know they should be doing it, and that's a start. Participated in blended finance initiatives with development financial institutions or multilateral banks. So for example, the IFC and the European Investment Bank, for the first time, are actually undertaking collaborative investing with corporations, and my fund is one of the groups that they're doing it with and through. Public-private partnerships. Governments, multilateral institutions should co-develop initiatives. Tactics have to do with co-investment of infrastructure or delivering technical assistance or logistics capabilities in humanitarian crises. That refers to basically, it's not enough to just drop an NGO into an area and do what NGOs do, but also bring along the population for self-sufficiency through well-organized and well-delivered programs. There's global value chain optimization. That's a term that only an MBA can love, where we redesign value chains to maximize local content, and we can do that through source materials from local producers in order to stimulate local economies, and invest in supplier development programs. And I'm not going to go through these now. There's some cross-cutting enablers, different things to think about here. There's technology and digital transformation as a component of that. Local empowerment and co-creation. Again, the co-design of products and services. You know, does it make sense for this sub-Saharan population to be coaxed into buying goods for suburban America, or should there be something else that's designed? And who should design it? Well, it should be designed here and ideally manufactured here, but that can be enabled through collaboration. Creating innovation hubs or accelerators, such as what you're doing here, which is exciting. All you need is some accompanying venture capital for that, and you've really got something. Engage in participatory planning with communities and civil society organizations. Some successful models, Unilever's Shakti programs, which train women in rural India as micro-entrepreneurs for hygiene products. MasterCard's Community Pass, which is very active in Africa. Danone Ecosystem Fund. It's amazing what you can do with yogurt. Co-invests with NGOs to support sustainable sourcing and local supplier capacity building. Some others, Path and the Microsoft AI for Health, predictive analytics for maternal mortality. Zipline, the program they have in Rwanda for drone delivery of diagnostic kits. I don't know if you're doing anything with them yet. Yeah. And then in Ghana, they're doing remote distribution of pharmaceuticals and supplies. And then there's Babylon Health, AI-powered triage in East Africa.
We wanted to thank you very much. This was a fascinating discussion. We needed a whole morning with you, if not a whole day, because because I think there are a lot of us who are working in product development and who face the challenges of something that's not going to cure cancer. And we wanted to give you
Thank you very much.
And we want to please for you to come and
Sure.
talk to all of us at the reception,
Happy to
just
do so.
down the hall to your left. Okay, it
All
was lovely.
Thank you
to meet
very
and
much.